Hello from Williamson Health. My name is Michelle Simpson. Thank you for joining us for this episode of Health Talks from the Inside Out. So Dr. Rebecca Baskin, thank you for sitting down with us today.
Oh, you're welcome. Thank you for having me.
Yes, of course. You are breast surgeon with our Williamson Health Turner-Dugas Breast Health Center.
Correct.
So let's start by telling us a little bit about yourself, your training, your passion for medicine, what got you here.
All right.
Yeah.
I'm actually from Murfreesboro, so I'm a Middle Tennessee girl. Grew up here. I did undergrad at Lipscomb and then went to ETSU for medical school and then Cincinnati for surgery residency.
Okay.
And basically I've been doing this for a while. So back then, there were not that many breast fellowships. So actually most of my training was on the job. We even did our own mammogram guided biopsies and ultrasound guided biopsies back then, as well as the surgeries. So that helps me with that hand-eye coordination for some of the placing guide wires for my own surgeries and things like that. I wound up specializing about 18 years ago in doing breast only.
Okay. And what about the specialty drove you to it? You just...
Well, I was actually fairly young and doing my own exam in the shower and found a mass in my breast. So I actually found a breast cancer and had breast cancer treatment. So I've been through a lot of the same things that these ladies are going through. And having gone through it and being on that side of it made me more passionate about helping guide women through this journey. It's difficult, it's emotional, but we have such better treatments and such earlier diagnosis and diagnostic tools now that that became my new passion. I wanted to specialize.
Wow. So you're a real life case at something difficult you went through.
Correct. Yeah.
You turned that and used that for good, and it shaped the rest of your career.
Mm-hmm.
Wow.
Later this year will be 20 years, actually.
Wow.
Mm-hmm. 20 years survivor.
Congratulations. And so how did you get to us at the Turner-Dugas Breast Health Center?
Right. Actually, it was Tim Burton and Carrie Ralph, who was the first navigator here that kind of set up the whole navigation process, which is a wonderful service to the men and women that go through this process. And so they were actually recruiting and approached me because I had done surgeries with one of the plastic surgeons that also worked here. Wow. So they asked me to come interview and to view how they had the breast center set up. And that's how I always wanted to have the breast center set up, where we are physically connected as well as just a good working relationship connected to the radiology department.
Right.
So the women can have their imaging there that day. Most of the imaging is read that day, and they're brought straight over to us, so it can be kind of a one-time visit. I think that decreases anxiety a lot, and a lot of women that work outside the home, they really need that ability and that convenience of not having to take off as many times for work to do separate visits.
And those two clinics are literally right
next to each other. So the women don't even have to change clothes. They can stay in the gown and they bring them through the back hallway to us. And they're already pre-registered at both places. So it's really a nice convenience. And then I think being so close, it's very easy for me to just walk over there and talk with the radiologist if I have any questions about the imaging. If we're trying to make plans, we have a very close connection.
Yeah. Let's back up a little bit with the Turner-Dugas Breast Health Center. What would you say is our mission there?
Well, I think just our mission is taking care of the breast health for both men and women of this Middle Tennessee community. So we don't just treat breast cancer. There are a lot of non-cancerous complaints that women have for their breasts. So we're treating things like nipple discharge, breast pain, fibrocystic tissue and cysts, palpable masses and cysts that aren't necessarily cancer. We also do see high-risk patients. So whether they've had previous biopsies with abnormal cells that weren't cancer cells, or a strong family history, or they've even had their own genetic testing and know that they have a mutation that puts them at increased lifetime risk of breast cancer. We have the services here with both mammogram, 2D, 3D, ultrasounds, and breast MRI. And then the capability of doing biopsies guided by all of those elements.
So truly comprehensive.
Correct.
And did I hear you say men and women?
Men and women. So it's much more rare in men, but we have had a few men in the last few years that have come through either with breast masses, things like 𝐇𝐞𝐚𝐥𝐿, which are benign, but we do have a handful of breast cancer patients that are men that we've been caring for.
Wow.
Yes.
Okay. So you went through the list. There are many other things other than just breast cancer that we are treating there at that breast health clinic. But since it is October, and October is National Breast Cancer Awareness Month, I did think that we would spend most of today talking about breast cancer, if that's okay. And I actually learned in research this morning that this is the 40th year.
I know.
That's been our national
right. I'm trying to increase, to increase awareness. I think that turns into more screening, imaging, and trying to catch the cancers as early as possible. That's our whole goal, is to catch things as quickly as possible so that the least amount of treatment is needed and the best prognosis and survival can be obtained.
Okay, so let's jump into that. What are the best ways for people to catch it early?
Right, and that's with screening mammograms.
Okay.
And women that have dense breast tissue, definitely here we have 2D and 3D tomosynthesis imaging. I tell people it's kind of like having an action shot of your breast where the mammogram arm that takes the picture starts to move, and the computer actually has software that reconstructs their breast into a 3D model. So the radiologist doesn't have just two flat 2D pictures to look at to try to determine if something is going on. They can actually scroll through that tissue like they would an MRI or a CT. That's about 40% more accurate for women that have dense breast tissue. And Tennessee is one of those states that made it basically a law that we need to let women know when they have dense breast tissue so that they know to ask, and they can ask for their own 3D imaging if it was only ordered as a 2D for their screening. And then also there are some women that are so high risk due to breast density, family history, their own history, that we also have MRI that can be added to their screening so that we can find things possibly even sooner than they would show up on traditional imaging of mammogram or ultrasound.
And if a woman doesn't happen to know that she has dense tissue, if she were to come in for a mammogram,
it's on a mammogram report that goes to their PCP, and it's also in their letter. So even if they have a completely normal screening mammogram, it will tell them that they have dense breast tissue and that they might qualify for additional screening or additional type of mammogram technology.
Okay, and then they'll know that going forward.
Correct,
so
correct. And then definitely doing the screening mammograms. I know the task force have talked about maybe not yearly until starting 50, but most of us still say start at 40.
Start at 40. Okay.
Also have a clinical exam with a practitioner. That can be primary care, OB, GYN. If you have a strong family history, want to be in the high risk clinic, it can be through the breast center as well. And putting together the mammogram and an exam together, we're going to catch the most findings that we need to then start to work up.
Great. And of course, we do recommend mammograms annually. Once you start those at 40, make sure you get
40. And then if there's a strong family history, especially of young women with breast cancers, you actually start that 10 years younger than the youngest relative when they were diagnosed. So if you have a relative that was 45 and she was diagnosed with breast cancer, you would actually start your screening at 35.
Okay. I didn't know that. Okay, that's a good tip. Good to know. And what about self-exams?
So if you look, American Cancer Society is not always promoting monthly self-breast exams always, but we typically say that is best to get to know your breast. There are a few women that have such busy breasts, it's probably better for them to have twice a year clinical exam with a clinician and their imaging. But for the most part, we still feel there are many women that can catch their own masses, especially in the under 40 age. Most of those women, because we're not expecting it, we're not doing screening mammograms yet, they're catching their own findings and coming to us, and that would happen too late if they weren't doing a monthly self-breast exam. So I'm still a proponent for monthly self-breast exam. It is best to do after your menstrual cycle when you have the fewest hormonal changes on the tissue, or if women are postmenopausal, then they can just pick the best time of the month for them and do it about that time every month. If you do it too frequently, you won't notice changes.
So be consistent.
Correct.
Okay, very interesting. Okay, so talk to me a little bit about that waiting period. Maybe if a woman something is found to be abnormal, maybe from one of these screening processes, what is that waiting period normally like for our patients before they get a diagnosis?
Well, obviously, because of high anxiety and because there are quality standards, we're going to want to try to get them in as soon as possible. Typically, we're getting people back within 2 weeks.
Okay.
Sometimes it's a few days. It's not same day because we've become so busy, but we usually can work that in very quickly.
Okay.
There's some women that put the brakes on and slow things down, but most women do want to do that very quickly. And so we work with them as quickly as we can. We also have that through a process where they can do it through navigation or the Breast Health Center. There are many of the physicians here that have a standardized form and knowledge that they want us to immediately start working up, calling those patients when they have abnormal imaging, get them in as quick as possible to do the diagnostic imaging, biopsy if it's recommended. Through the Breast Health Center consult and the navigation process, they're then going to get a call. Benign calls come very quickly through the radiologists who do the biopsy. Anything that is concerning in cancers are called by the navigators. Okay. So they have someone very knowledgeable that they can ask some questions from that initial phone call. Those navigators then start navigating or helping them go through the process of figuring out which medical oncologist they want, surgeon they want, who do they want to start building their team, because this is a multidisciplinary way that we treat breast cancers. They're going to have a few specialists, actually.
Mm-hmm. And you've mentioned the navigators a few times. Right. So that is something that we're very proud of. And we
the program here is unlike anywhere else I've been. And so they do actually start from the very beginning. They start helping with the abnormal mammograms, that they really start the phone call and the personal connection to the patients when they've been diagnosed. And so they will talk with them about, personalities and speed that they want to go and help them figure out. We have amazing clinicians here. We have 3 groups of medical oncologists they can choose from. With Tennessee Oncology, Vanderbilt, and Sarah Cannon, we have working relationships with all of those groups. They have the Williamson surgeons. They also have a Vanderbilt surgeon. Most of the women do want to stay here locally and stay as a part of that navigation process.
Mm-hmm. So it's literally a person that is just with you every step of the way.
Correct.
And it's that person where maybe you can't talk to the doctor multiple times a day, but you can
phone calls.
But you can call the navigator and ask the questions and share your fears and I've heard them talking with
and
partners.
they come directly to us. If they don't know how to answer the question, they will come directly to us. We review their MRIs. We help them with the next steps to make sure that they get to their physicians fully worked up.
Yeah. Mm-hmm. So let's round out the rest of the team. So we've talked about you as breast surgeon, and you have a colleague,
the radiologist. I do have a colleague, Dr. Slater.
Yep. So
and then there's also Dr. Brown, who does breast surgery here as well.
Okay.
It really starts with the radiology team and the technicians, but we also have in our office with us, we have schedulers, we have a surgical coordinator that helps us get together all of the consults and try to prioritize everyone, get everyone in as quickly as possible. And with the navigators, they get all those things scheduled for them. Like many of them need, or we recommend MRIs after their diagnosis. So we're trying to get everything lined up and all those appointments for them. And then they help us as well with the education that happens before surgery. So I think between the navigators doing some cancer navigation before they see their surgeon or medical oncologist helps a lot. I think just repetitive nature of hearing the information and being able to ask those questions gives them ownership of being able to help make their own decisions of what they think is best for them. And then we do a very good education process before surgery with the surgeon and the surgical coordinator, and all that, those perioperative questions and instructions, and even drain care and teaching and demonstrations. And then the navigators help in the hospital before discharge as well.
Wow. And we also have a few nurse practitioners on the team, right?
Correct.
So they might see one of them in office instead of...
Correct. Yeah. So they see many of the benign patients and the high-risk patients, help them get their scheduling done. They do their exams, really make that connection and that relationship with them for that longevity or continuity of care. But they also help us after surgery. We tend to alternate. So they're the whole team winds up being familiar with the patients. These are typically following those cancer patients for at least 5 years, and their medical oncologists are following them oftentimes for 10.
Right.
So it does become a very personal relationship with everyone, and that is one of the things I like about breast surgery, is that continuity of care that we get that you don't necessarily get when you see someone for a sick appendix or a gallbladder.
Right.
You know, you just don't have those years with them.
Right. Okay, so let's talk some about treatment options. So if someone is diagnosed with breast cancer, what might then be the next steps?
Right.
Yeah.
So most of the patients are going to go first to surgery, but sometimes women need chemotherapy first. And so we do coordinate and work very together with their medical oncologist in choosing the right order of treatment to get them the best outcome. For surgery, then they have options for breast conserving surgery, and then there's the option for mastectomies with or without reconstruction, and we have an amazing team of plastic surgeons here too, several plastic surgeons that we work with that are very experienced and take insurance, so that can take some of the stress off those decisions. Genetic testing, we're oftentimes doing genetic testing for that patient, because if they have a certain mutation, especially BRCA1 and BRCA2, we may make different recommendations for them for surgery, a bigger surgery, maybe a both sides surgery, because their risk is greatly increased of having a second breast cancer in the next 5 years. So we offer that, as well as medical oncology offers that service to help the woman have all the information she needs to make the best decision for her. We have wireless technology now for women that want to have lumpectomies. So we have ways that I can either place wires by ultrasound guidance in the OR after they're asleep to get to that right location, or if we need to, then we can do it wireless by radiology ahead of time, usually mammogram guided, can be ultrasound guided. So once again, team effort to get these patients to surgery. If they choose mastectomy with no reconstruction, then their surgeon is in charge of their postoperative care and drains and follow-up. Many of the women around here are choosing reconstruction because we have so many options and resources for that. And so we send them to the plastic surgeon and network of their choice, and we work as a team so they can start rebuilding their breast, start that reconstruction the same day as their mastectomy. So it's just one step closer. I think that's very important, not just physically and timeline, but I think psychologically that's very important.
And it just goes to your point of how closely you are working with the rest of the team, including the plastic surgeon, that I say while y'all are in there, you're together making a plan.
We are. So they see them ahead of time also to make a plan ahead of time. So we go in with a strong plan and a backup plan depending on blood supply and anatomy. And they already have the supplies in the room. And then we're actually overlapping some of our work and working very close together in the OR at the same time.
Okay, you used a term that might be new to some patients. It was to me. You said breast conserving.
So that's another word for lumpectomy.
Okay.
So so that's another word for lumpectomy. We have I guess a movement in the lay literature that people are wanting to call it breast conserving surgery. And I think that was to really stimulate that there are many more women now that are candidates for lumpectomies and still having a good cosmetic outcome, whether it be the way that we plan their surgery, that sometimes we're shrinking their cancer size before surgery if they need chemotherapy, or we've got oncoplastic methods and things like that. So it opens up a better end cosmetic result, I think, for women. So they're really wanting us to be able to talk more about saving or conserving breasts and breast tissue, that women don't automatically feel like they have to go for a much larger surgery. There's no difference in survival, but there is a big difference in their recovery, obviously, their recovery time and effort.
That's an important thing, what you just said, though. Statistically, there's no difference in survival.
There's no difference. There can be some small percentage difference in local recurrence, but there's no difference in survival between lumpectomy and mastectomy. So if someone is a good lumpectomy candidate, that's a great option. We want to make sure that they know that they can have a cosmetically pleasing end result with that.
Wow.
Many women with lumpectomy, they do need radiation. We also have those radiation oncologists here in town, both with Vanderbilt and Provision. So we've got options for them as well here locally to get them that best end result if they choose lumpectomy or breast conserving surgery.
Great. Okay, you mentioned genetic testing. So that was one thing I was interested in asking you. So do we offer that at the breast center?
We do offer it at the breast center. We send it to the 𝐷𝐵𝐸 lab. So we draw the blood work to send and do the paperwork. There are some women that their insurance may not cover it, but the company has worked with the patients so that there's a baseline amount that's only a few $100s, so that if their insurance doesn't cover it, they could still get that information for themselves and their family members. There are definitely mutations we talked about, BRCA1 and 2, where we make strong recommendations for bilateral mastectomies because those women have a 60% chance of having another breast cancer in the next 5 years. So we're really trying to prevent recurrence and new cancers in the near future. There are other mutations that are also related to breast cancer that can lend 20 to 40% range of breast cancer or a second cancer. And in those women, we want to have a little bit longer conversation about do they want a larger surgery or a bilateral surgery? Bilateral means both sides.
Right, both sides. What would you say is the most rewarding part of your job?
I actually like the continuity of care that we have for breast cancer patients. So I just don't operate on them and see them once in the post-op visit. I'm with them for the next 5 years. I mean, you know, we may be alternating and sharing with the nurse practitioners, but they get to know that entire team. And just to see these women go through something that is very physically and psychologically difficult, how strong they are, and how many of our patients have started to give back to others, whether they work for the BRA program, the ABC program. So I think that's wonderful to get to see that growth and to see them get stronger again after surgery. I think is wonderful.
Well, and I know they love you. So we hear wonderful things all the time about how much your patients love you. Speaking of charity and some programs that give back, can we talk about the Pink Chair program that we offer through our Williamson Health Foundation?
Yes. So women that do not have the financial means and that are especially going to have very large surgeries and have a lot of restrictions with their arms so that they can't push or pull themselves up out of a chair, out of bed. They have the Pink Chair, and the Pink Chair Foundation allows a recliner, and I think it's for 4 to 6 weeks in the home. So they'll clean it, they'll bring it, they'll pick it up when they're done with it, and that allows the women to sleep more in a reclining position instead of flat. And in some women, it can make them a better candidate for a larger surgery and make it safer and decrease the risk of complications because they have better mobility getting out of the recliner than maybe they would off of a chair, couch, or the flat bed.
And to some that might seem like such a small thing and something that you might not even think about.
Those are
that
very
needed.
pricey items though to get for your house. And to really maybe only need it for several weeks after surgery. So I think it's been a great service, a great charity for women. They brag about it all the time. That's really made their recovery in the first 2 to 4 weeks after surgery much easier. And I think it helps their family feel better about taking care of them. They have a little bit more ability in getting up quickly to go to the restroom and things like that.
So if somebody's going through a breast cancer journey or knows a relative or a friend, you can go to our website, get on our foundation page, and that's something that people can apply for. So
And I think they deliver to within Williamson County.
So as we're in October and we are celebrating the 40th anniversary of National Breast Cancer Awareness Month, what is the one thing you want women to know about our breast health?
I don't want them to be scared to get their mammograms. So I think the new 2D, 3D tomosynthesis mammograms gives us better pictures. I think there's less complaints of compression and pain. We also have the Smart Curve paddle, which is a little bit more ergonomic in the way it does the compression, especially for larger or denser breasted ladies. And I think that for all of us, procrastinating is its own stress. So I don't want women to be scared to get their imaging. I want them to feel like they've taken ownership. They go ahead and get that screening. They do their yearly clinical exams with their physicians and make sure they're being very proactive in their own care.
Now, how can patients find you?
Okay, we're at the Turner-Dugas Breast Health Center. We're associated with Williamson Medical Center and Williamson Medical Group, and we're just on Carruthers Parkway, just down from the hospital.
Okay.
So,
and can patients call you directly? Do they need to have a physician referral?
So we do prefer a physician referral so that we can get like a history and physical and know more about their medical status, but they can call us directly and start that self-referral process, and we can help them with that. The biggest thing is trying to get their imaging here, but we do now have a way through our IT department that many of the places nearby can electronically send us their imaging into our PACS system, because obviously as proceduralists and surgeons, we need that imaging, and our radiologists need the imaging, especially if it's abnormal, to make plans about biopsies and follow-up and things like that.
Wonderful. Thank you again for being with us.